all of that tells us that there's a significant likelihood for a reduction in total billings. The people who most likely are to suffer from that are the doctor group, the passive group, who are waiting for patients to come, waiting for the appointment book to be full, waiting for the practice to supply the patient demand, will be thinking how the earnings have dropped. And they're going to approach the practice, and their only solution they could even consider is, hey, can you reduce my service fee because I'm not earning enough? And so if you're a practice where you've seen this happen across 3, 5, 7, 10 GPs, where billings have gone down, at a practice level, you're going to have a significant impact on a revenue generation point of view.
All right, welcome back to the Skull My Clinic podcast. Welcome, Sachin.
Hey, Todd.
That's your cue to say something, man. So we are coming towards the end of 2025, and the purpose of this podcast is to go through the potential quadruple whammy that your practice might be facing. First thing, the mental health item numbers are disappearing. Not all of them, but some of them, and the most widely used ones. So that's just going to talk to you more about that. So again, the feds have fixed mental health. It's no longer an issue in general practice. So all of your patients should be smiling and easy to look after as of the 1st of November. The other thing that's going to be happening is there will be a bunch of clinics that we're privately billing somewhere between 10 and 30% of their patients that will probably decide to go bulk billing. So we'll end up with more bulk billing clinics and less clinics in the mixed billing and full private range. And what that's going to do is mean that those of you that are in the mixed and private billing range may notice a short-term drop in your patient numbers, particularly if you haven't done any pre-planning like people in Project X. The other thing that usually happens when you get a drop in patient numbers is you'll get a drop in GP income. And Sachin and I can tell you that usually what happens after a drop in GP income is the GP comes to you as an owner and says, I don't really like this very much. I know we all agreed to do what we're going to do, but how about you give me a higher percentage as a GP retention, you take a lower service fee, and we sort it out that way. I strongly recommend that you do not adopt that course of action, that you need to listen up for what's coming. And then the last thing that's likely to impact numbers is, and this is playing out in clinics all over Australia already, you got to do some of the high volume item numbers. And guess what? Your patient that you enrolled in MyMedicare is now enrolled at St. Elsewhere. And so you are not able to process the numbers that you want to. And so there's this MyMedicare cheeky business going on where people are being enrolled wherever they show up for whatever reason without their consent oftentimes. And you're playing against some really big and well-organized, well-resourced players in this space. All right, Sachin, let's hit them one by one. Let's go through the quadruple whammy. Tell us all about the mental health item numbers. What's going?
Yeah, well, from the 1st of November, the magic wand has been waved and mental health issues are dramatically reducing. Leaders have fixed it, and so we no longer need items 2712 and 2713. So 2712 was a review of a GP mental health care plan. 2713 was a mental health consultation, at least 20 minutes. Now, both of these have been used to varying degrees, often co-billed with standard items, especially when multiple issues presented, with the 2713 especially. And with the 2712, we were told that it's important to review mental health conditions once they've been diagnosed and a treatment plan's been made. And we've been told in chronic disease that we need to do more reviews, which is why the change was made. Yet, magically, in mental health care, we're now told reviews aren't necessary. Who'd have thunk it?
Amazing. Yeah. You're not suggesting for a second that there's hypocrisy at the government level, Sachin. I hope that's not what you're suggesting.
I would never dream of it. However, that's $150 million ish annually wiped out from those two item numbers funding. So that means the real risk there is for especially privately billing and mixed billing practices that would co-bill. Maybe they would privately charge a 23 and then bulk bill the mental health, or vice versa. That the ability to do that now is no longer going to be possible after the 1st of November.
Could you talk about the doctors? Like, what's the profile of the doctor who does this? Because I think there's a lot of these doctors who don't know what's coming for them, and it's not going to be a lot of fun for them because it's a substantial defunding of the way they work. So these people typically look after chronically unwell, complex patients with mixed mental health and chronic medical conditions, which we know go hand in hand.
Yeah, so undoubtedly it's women that are affected more, both as clinicians and patients. Something like 25% of female patients present with mental health conditions versus 18% of male patients from the last figures I've seen, which means that's a substantial amount of women that are more adversely affected there. And generally speaking, it's not every doctor, but generally female doctors tend to work a bit slower and deal with more of the complex mental health conditions that present. And I think the data shows that, and anecdotally as well in the conversations we have, we see that show up. And so there is an argument that there is gender discrimination at play within these changes. Whether that was intended or not is a different issue, but the reality is that the numbers show that this group is going to be adversely affected, both as patients and doctors.
Let's be blunt. If the federal government, in making these changes, don't run them through a filter to check are we adversely impacting certain groups of people, then it's the same as not giving a stuff about it, because they do not care about the fact that they are targeting mostly female patients and mostly female GPs. They don't give a stuff. That's the main message you can take from it.
Because they care about the votes more, and that group is not going to add up to many votes. So at the end of the day, you can let go of those people. It doesn't matter because they're playing a numbers game. And that is true. That's the reality. And the writing is on the wall. And if we haven't prepared, then the way that's going to show up after November is, in some cases, if you're seeing 2 people like that an hour or 5 people like that a day, then if you've got 5 of those consults that disappear in a day, that's probably about $500-ish. And if you're working 3 days a week, that's $1,500-ish of billings, and across a year of 40 odd weeks, that might be $60,000 to $70,000 of reduction in a GP's billings. But probably it will still feel like you have to do the same work, just for reduced. And so unless real steps have been taken to think about how to address that, we've been doing that work in Project X, but if that hasn't been done, then that will be painful both for the GP and then ultimately also the practice. And there's real risk of more burnout, more frustration with the system from a doctor's point of view, for sure.
And back to that doctor, so 3 days a week, using the numbers you just talked through, we're talking about $800 to $1,000 per week of reduced salary or not salary, income after the GP retention before tax that is now missing for the same amount of work, or you have to adjust your fees. And so patients will be paying on average sort of $80 to $90 more per consultation. That's a really big gap for them to cover in a short time if they haven't been pre-warned or pre-educated about that, or you've got to go and find a bunch of people who can afford that. And then it means you can no longer deliver care to that group of people because it won't be appropriately compensated. So as a GP delivering care and as a patient receiving the care, there's a change that you have to undertake. You can no longer have situation as normal, because if you do the same work and you don't adjust your fees, then effectively you're agreeing to work for a substantially reduced amount. Doesn't make a lot of sense. And if you are going to try and even just get parity back, then your patients will be paying substantially more. So let's jump into the next one, Sachin. Bulk billing clinics. Elbow promised us that we would have 90% of clinics bulk billing, even if we don't get to 90%, effectively you're going to see a jump in the number of clinics that bulk bill, even if people do it for a little while and then revert back to mixed billing. How is that going to impact clinics that are mixed billing or private
I just
billing?
have to do this one thing. 90% will be. I've covered it up.
Is that now? I'm serious here, Sachin. Is that your elbow impression?
It's the best I could do at short notice. So, I was like frantically trying to get my Medicare card out. So, look, we're coming to November, and when I was thinking about this the other day, it's probably not a surprise that this has come in November, because they've probably planned that number of consults drops at this time, and so you really got November, December. I know everyone knows the months of the year, but you've got probably 3 to 4 of the quietest months coming traditionally in terms of patient demand, apart from like Christmas Eve, where everyone's like, oh God, I've got to get every single thing sorted before we're shut for like 3 days. But anyway, this is that time. And so you've got natural reduction in patient-driven demand. And then, from what I've observed, there's quite a lot of practices, especially some of the corporates, who are really looking to flood certain areas with UBB, universal bulk billing practices. I spoke to someone who's in the Northern Territory a couple of weeks ago, who said a corporate has opened like 8 practices in and around Darwin and brought like 20 plus UBB GPs there in readiness for this. And these people are just twitching, they're just twiddling their thumbs, waiting to get started, and there's not enough demand for them. And so just with market forces, it wouldn't be unusual for, if there is a higher supply of UBB appointments, that some of the patient cohort will look for a cheaper solution, especially if you haven't done the preparation and the communication up front. And so what you can expect, both with seasonal changes and with the added bulk billing changes, that there could be significant gaps opening up in the appointment book. And if you notice less appointments, then there's 2 things going to happen. Those appointments that are coming, if you haven't handled the comms well, then they're going to be asking to be bulk billed. So you're going to have more conversation, more complexity there. And invariably, if you're someone who is not prepared or hasn't been through the preparation, then it may just be easier to cede to those demands than actually hold your intended billing policies. So that's at an individual level. The GP may feel that pressure, and at a practice level, that may then impact the practice, and the practice may not have had any leadership in this process with their doctor team. And so the combination of all of that is really to say that it wouldn't be unusual to see or predict that there's a significant drop-off in utilization of your appointment capacity. And so if say you have 5 doctors and there's 5 spare slots a GP, at an average normally of say 100, and then you've got 25 spare slots a day, it's 2,500, 5 days a week. That's effectively like a full-time equivalent of billings just there, just empty and not being utilized. And that is a significant potential loss to the individual clinicians and at a practice level at a time when there's been record pressure on the cost base of running a practice. And so that's something that has to be taken seriously and planned for meticulously, because without actively planning to mitigate, and I've talked about a few things there's the pricing element, there's the appointment capacity element, there's the leadership with the doctors. If those things are not addressed together, that could be very harmful to a practice's revenue model. And that's before we get to whammy number 3.
Whammy number 3. So just on that note, so Sachin and I, you and I at the moment are determining who comes into Project X. So if people have a call, they talk to you, and then if they get that far, they talk to me. The worst answer for what are you planning to do around the November changes, and an unfortunately common answer is, I'm waiting to see what everyone else is doing. So then you lose any tactical benefit of choosing a path and just sticking with the path, building out the business to suit the path you've chosen. And you're just reactive anyway. And if you have to try and turn the ship around really suddenly, then you're going to throw a few people off. You're going to have doctors that weren't prepared for that and they're ready to go. You're going to have patients that weren't prepared for it. You're probably going to lose some staff it's not going to be a good idea to wait and see what everybody else does. I think the other thing that's happening in the background that's causing reduction in consultations as well is pharmacists taking on, pseudo roles of doctors, thinking that prescribing equals a consultation, and a lot of the private services that don't show up, which are scripts, the certificates, etc., and some MBS-funded services that will have the same rules as general practitioners. Nurse practitioners have been able to do MBS-funded telehealth up until the 1st of November. So all of those things have been driving a reduction of GP consults, as well as the forces that you're talking about. Are we okay to move on, Sachin?
Yeah.
All right. Now, let's get to MyMedicare, and then we'll talk about the quadruple whammy, the fourth one, once we've done MyMedicare. Tell us about that.
With MyMedicare, what we are hearing and seeing and observing is that patients, even when they've been registered at one practice, may be visiting another practice where there are, and with any system, there's always some abuse of the system, and there are two types that are going on. One is, which I think unfortunately is more common, is that people are unwittingly being switched as MyMedicare registered when they attend another practice that isn't their intention. The patient has no intention. They may not even understand what MyMedicare is. But what's happening is when they go back to their home practice, let's say, that practice does their usual chronic disease item or whatever, and then it gets rejected because the patient is registered elsewhere. Now, anecdata tells us that quite often the patient says they're not aware, they haven't signed anything or done anything electronic to allow that to happen. But who knows the actual mechanics? People may have just been sent a text that says click here. We don't know. But what that means is, because the patients aren't well educated or about MyMedicare, what that means is that they are unwittingly going somewhere for a minor issue, maybe for convenience, or maybe they're away from home or something. And then when they go to the home practice for regular care, there's an item number rejection, and that leads to a combination of things. From a patient perspective, it might delay or remove the ability to get a rebate if it's a privately charged service. It may delay or reduce the ability to get access to other services that are related to their chronic disease item. And from a practice point of view, there's a whole admin burden about fixing that up. And from a GP perspective, either they have to wait for the payment, which who knows how long that might be, or they don't get paid. And they get frustration related to sort of all of the above. And so that in itself will affect cost. It will affect patients. So, for example, if patients unwittingly get snared by another practice and then fall into their sort of normal chronic loop, even without intending to, they may then disengage from the regular practice that they were going to. And that's a real risk with a number of patients if it's not done in an open and transparent manner. And so the impact of that is you could lose patients to MyMedicare registration. And we know that future enhancements and funding is going to be attached more likely to MyMedicare than just fee for service. And so you do need to have a strategy for MyMedicare and an education process so people know not to just sign up somewhere, and to make it clear that that place knows. The patient tells them, do not sign me up to MyMedicare here because I'm over there.
Absolutely, Sachin. And because this is such an important thing, that patients understand the place of MyMedicare, that it stays with their home practice and it doesn't get moved around. You'll have seen all of the marketing and work done by the federal government to promote MyMedicare and explain all of that to patients, because it is a substantial administrative burden for general practices. Do you remember those ads? No, you don't, because they don't exist. That's why. And so again, practices are taking on, it wasn't enough that we took on the jobs of the Medicare officers, organising their rebates and doing all that for them, get paid originally. Now you don't get paid to do it. Now you're doing all the admin for MyMedicare and all of the palaver that goes with that, because it's messy and it does not work as it was advertised. That's now your responsibility to educate and deploy that strategy. And that's going to absorb a large amount of administrative resources. And then if you're telling your GPs it's not working anyway, guess who's going to get blamed for that? Now, Sachin, talk to us about what happens with all these things, how they all come together in one great confluence that the practice owner does not want to see in the next few months.
So I think we've had a bit of a giggle, but probably this last one isn't really a laughing matter. Like, you have to laugh because some of it is absurd, but this last one I think is something that you need to be really acutely aware of, which is, especially if you're running a private or mixed billing practice, it will be less so probably for bulk bill practices because there's some other sugar hit coming with the bulk billing change. However, it could affect some UBB practices as well. And so, especially if you're in an area that gets saturated with UBB services. So I'll probably recant and say this applies to us all. So if you've got a situation where two common item numbers, especially common for co-billing, have been removed, then we know there's a billing downward pressure, number one. Number two, we know that seasonal changes and an increase in the availability of UBB consults is likely to lead to a downward pressure in appointment demand. So, second cause of downward billing pressure. Third part, which is sort of part 2B, is that for some reason, many doctors feel a bit disconcerted when the appointment book has gaps. So there's the financial, like rational reduction in billing, but then there's an emotional element of uncertainty when there's gaps in the appointment book, depending on what color you keep your appointment book. Maybe keep it gray so that it looks like it's just a completed appointment. It'll be an interesting study to do. But there's duality there from there's the sort of rational side, and then there's the emotional side, and then you've got this situation where the MyMedicare are sometimes paying, sometimes not paying because of the things we just talked about. All of that tells us that there's a significant likelihood for a reduction in total billings. And so, in my experience, the people who most likely are to suffer from that are the doctor group, and maybe you're a GP who's not an owner listening to this, who are the passive group. That is the group who are waiting for patients to come, waiting for the appointment book to be full, waiting for the practice to supply the patient demand. And so that group in particular, but there will be others as well, will be thinking, oh, I'm feeling this pain. My earnings have dropped. And they're going to approach the practice, and their only solution, the only one they could even consider, is, hey, can you reduce my service fee because I'm not earning enough? And so if you're a practice where you've seen this happen across 3, 5, 7, 10 GPs, where billings have gone down, at a practice level, you're going to have a significant impact on a revenue generation point of view. Now, you've got GPs saying, guess what? I want more of that, and I want to give you even less. And all of that combined with the increased costs of some of the complexities of MyMedicare means that there is likely to be an existential risk for practices who have not prepared for this. And I don't mean preparation as in one conversation. I mean a really thorough plan, and for things to have been put into action to mitigate for this. Those practices, some of those practices are not going to know what's hit them, or they will if they've listened to this and then don't act. They'll know why, but they won't have a solution. And so what I'm saying is that group is at grave danger if they don't act now. And that danger is going to hit like one thing after another, and it may be like a set of dominoes that just falls, and then you sort of reach a bit of a tipping point, and then there's no coming back, especially if then you get doctors who are being chased by people, whether they're promising realistic things or not. If people feel uncertain, worried, and you're not able to meet their demands, or you're in a catch-22, you either meet their demands and suffer, or potentially don't meet their demands and suffer. And so I'd go with the third option, which is act now and mitigate for that massive risk that's on the horizon.
So that's a nice segue, Sachin. We work with practice owners in Project X, and those practice owners have been working on this for months already. Like, they're well prepared for this. And so this reminds me of one of Stephen Covey's rules is begin with the end in mind. And so let's talk a bit about that. So maybe an opportunity to share a little bit of an overview as the kind of work we've been doing in Project X more recently, just around the different things that people can do that mean that they are able to get on the front foot with this.
Absolutely. I'm going to keep going because my camera has done something which has gone off.
It's turned out you're just too sexy for film, and so you've been turned off, which is fine. We can all imagine what you look like. So keep going.
Perfect. Yeah, there's quite a few things we've been working on with our Project X cohorts on this. And so what are those? Just to name a few, the types of things to be thinking about are, where are unnecessary costs in my business that I can sort of remove or reduce? So that's number one. I think the big ones from a cost side, there's probably looking at our staffing and resourcing. That's going to be important. We need to think of, how are we the practice of choice? Like, how do patients choose a practice? Typically, they'll speak to other people or they'll go online and they'll do a Google. When they do that, they may come across reviews. So we need to be thinking about, from a review perspective, am I standing out? And my camera's back for a while. We don't know if it will last. Then we need to be thinking on pricing. Is our pricing congruent? Does it make sense? Are we charging appropriately to mitigate whammy number one that we talked about in terms of the loss of the mental health items? Then we need to be thinking about buffer, I call it, book an appointment from an appointment. We've been working on something called the $1,200 patient. I think that's going to be a really important thing. There are certain patients who require longitudinal care ongoing, and they need it well planned. So we're going to need to move to a planned care approach. And then, of course, if we're charging people and we're seeing them regularly, we're going to need to make sure that debts aren't getting out of hand. Because no point people going through being seen more but not paying their bills.
Not paying.
And so those are the things we need to think about. If we are in a situation where capacity is an issue, like, recruitment, GP recruitment's an issue, then we need to think about, how could we move some of our work asynchronous for more of the simpler stuff. So where people they're already using these online services that give a script or whatever. How could we do that for our patients in a way that's sustainable for us as a practice, frees up some capacity for some of the more complex work that we could do? And then what are the things we hate doing that we don't get paid for, or we don't receive adequate payment for, or we're not charging enough for from a paperwork perspective? We put all this together in Project X, and we've been working on something called the Epic 8. And as per the label, some of the results have been epic. People have done some really cool stuff, found some really substantial uplifts there. But that's the way people need to be thinking about, where do I need to put my attention to mitigate some of the risks that are on the horizon? And you can do it in two ways. You can sort of do it ad hoc, piecemeal, a little bit of this, a little bit of that. Or if you want some help with it, you know where Todd is, you know where I am. Just reach out to us and we can talk about what that looks like.
Yeah, absolutely, Sachin. I think we've talked through the quadruple whammy coming your way if you're not intentional about what you do in the next few months. Remember, you'll have a BAS due probably mid-Feb from your December quarter as well. So it's not fun to have a quarter where you decelerate, then you've got to pay out some extras to the government. They'll be bragging about giving you extra. You'll be giving extra back. That's a big deal. And I think the other thing Sachin was just talking about there is you want to make sure that you're hanging out with the right people that are thinking the right way. I think it was Brian Tracy that said you're the average of the 5 people you spend the most time with. May have been Stephen Covey who reiterated the thought, but that's true. You do want to make sure that you're hanging out with people that are thinking the same way about their business. And it's not just practice owners, but practice managers as well, because ultimately they're the ones that are implementing a lot of this work, and they're the lieutenants that are making sure that it goes through, that it gets done well. So, Sachin, thank you for being in my group of 5, helping to lift the game or lift my performance. For all of you here, Get moving, be intentional, don't be passive. And if you do have passive GPs, you need to start speaking to them now and make sure that they are forewarned. I've been Todd. Thank you, Sachin.
Cheers, Todd. Before we go, I have one last message, which is if you're one of those GPs, if you're one of the GPs that this could be relevant to, it applies to you even more so to go to your practice and have a collaborative conversation. It's not a time to bury our heads in the sand. I think it's really important. Practice owners, you need to go and create an environment where you can have the conversation with the GPs. If you're a GP, it's equally incumbent upon you to go meet halfway, and it will require a bit of work on all parts to get ahead of this, but there's time. But only if you have the conversation and act now. Thank you, Todd.
Thank you, Sachin. Bye all.